Oral administration. Oral administration refers to delivering medication through the mouth into the gastrointestinal tract. The effect usually appears more slowly compared to other routes, but tends to last longer. However, gastric juices may interfere with drug action, absorption is slower, and the amount absorbed can be difficult to predict accurately. Advantages include safety since the skin is not penetrated, convenience, low cost, and relatively few side effects. Disadvantages are that it is not suitable for patients with swallowing difficulties, nausea, vomiting, unconsciousness, or those who are fasting. Some drugs have an unpleasant taste or odor. Gastrointestinal motility disorders can interfere with absorption, and irritation of the gastric mucosa may cause nausea and vomiting. Certain drugs can discolor or damage tooth enamel, and overall effectiveness is lower than parenteral administration. Forms of oral medications include capsules, powder or liquid enclosed in gelatin, useful for irritating drugs, tablets, compressed powder in solid form, pills, round or oval mixtures of one or more drugs with binding agents, sometimes coated for delayed release, powders, absorbed faster than tablets, less prone to spoilage than liquids, elixirs, sweet aromatic solutions containing water, alcohol, and flavorings, syrups, sweetened preparations masking unpleasant taste, and lozenges, dissolve slowly in the mouth for local or systemic effect. Contraindications for oral administration are patients with dysphagia, impaired consciousness, strict NPO status, or severe vomiting. Preparation and procedure include ensuring enteric-coated drugs are never crushed or chewed, positioning the patient upright or on the side to prevent aspiration, and avoiding use of medications with missing or unreadable labels. Medications should not be poured back into the original container, and only the required dose should be dispensed. Any discolored or precipitated drug must be discarded. Before administration, allergies should be checked and the purpose and effects explained to the patient. If the patient refuses, the reason must be documented in the chart. Special considerations include diluting or using a straw for drugs that stain teeth, e.g., liquid iron, or damage enamel, e.g., hydrochloric acid preparations. Crushing and mixing with food may be allowed except for enteric-coated drugs. Ice chips can be used before administration to reduce unpleasant taste. Oil-based drugs should be refrigerated. A dropper may be used to place liquid medicine between the gums and cheek to avoid triggering the gag reflex. Patients are encouraged to rinse the mouth or drink fluids afterward, unless contraindicated. Pediatric administration requires sitting or semi-reclining position, often using a dropper. If swallowing is difficult, tablets may be crushed or capsules opened and mixed with soft food, but never with favorite foods or milk. Children should be given clear explanations when possible. Geriatric administration requires more time and patience. Massaging the throat or under the chin may help with swallowing. Dosages should consider kidney function, weight, and age. Elderly patients may need support in following medication schedules, and side effects must be monitored carefully. They should be taught to identify medications by name rather than by color. Sublingual administration places the drug under the tongue, where it dissolves and is absorbed quickly into the bloodstream. The patient must not swallow the drug or drink water until it has fully dissolved. Because of the rich vascular supply, systemic effects occur rapidly. A classic example is nitroglycerin for angina. Nasogastric administration delivers medication through a feeding tube inserted into the stomach. Solid drugs are crushed and dissolved in warm water, and liquid drugs are given at room temperature. The tube is flushed with 15 to 30 milliliters of water or saline before and after administration, and the patient is kept in a semi-Fowler's right side position to promote absorption and prevent aspiration. Parenteral administration means giving drugs by injection, so the medicine bypasses the digestive tract. The main routes are intradermal, subcutaneous, intramuscular, and intravenous. This method has several advantages. It allows rapid drug action and complete absorption. It can be used for patients who are unconscious or for those who cannot take oral drugs because of stomach irritation. In emergencies, it is the route of choice. But there are disadvantages too. There is a risk of infection, of air embolism, or of tissue damage. Side effects also appear quickly, and in severe cases, an allergic reaction can be fatal. Injections may cause pain and anxiety. They require sterile equipment and strict aseptic technique, and they are more expensive than oral drugs. Once the drug is injected, it cannot be taken back. Intradermal injections are mainly used for diagnostic tests. Examples include the tuberculin skin test, allergy testing such as penicillin sensitivity, and vaccinations like BCG. Common injection sites are the inner forearm, the lateral or posterior upper arm, the upper chest, and the area just below the scapula. The standard procedure uses a 1 milliliter syringe with a 26 to 27 gauge needle. No more than 0.5 milliliters is given. Most often, only 0.1 milliliters. The skin is cleaned with alcohol and stretched taut. The needle is inserted about 2 millimeters into the dermis at a 15-degree angle. A small wheal, about 3 to 4 millimeters, should appear. The needle is withdrawn quickly, and the site is not massaged. The injection site must then be observed for a reaction. For allergy testing, it is checked after 15 to 30 minutes. For the Mantoux test, also called the tuberculin reaction, purified protein derivative, PPD, is injected into the inner forearm. The site is read 48 to 72 hours later. An induration of 5 millimeters or less is negative. A reaction of 5 to 9 millimeters is doubtful, and retesting with patient history review is needed. 10 millimeters or more is positive, suggesting possible infection, although confirmation requires a chest X-ray. A strongly positive reaction is defined as redness over 15 millimeters or induration over 10 millimeters. Subcutaneous injections deliver medication into the layer of fat and connective tissue just beneath the skin. Common sites include the outer upper arm, the anterior thigh, the lower abdomen, and the area beneath the scapula. Among these, the abdomen and interior thigh are most often used for insulin. Nurses often use the upper arm and abdomen. For heparin, the abdominal area above the iliac crest is chosen because it reduces the chance of hematoma. Indications for subcutaneous injections include preventive vaccines, preoperative medications, narcotics, insulin, and heparin. But complications may occur. These include atrophy of subcutaneous fat, skin dimpling, tissue damage, infection, induration with tenderness, abscess, or hematoma. Special precautions apply to certain drugs. With heparin and insulin, the site must not be massaged after injection. For insulin, injection sites should be rotated systematically: outer upper arms, upper back, buttocks, and abdomen, keeping at least 2.5 centimeters apart. This prevents lipodystrophy. For heparin, the plunger should not be aspirated before injection to avoid hematoma. The airlock technique is recommended. The needle is inserted at a 90-degree angle, and the skin should not be pinched or massaged during or after the injection. The procedure is as follows: clean the skin with antiseptic, gently pinch the subcutaneous tissue, insert the needle, do not aspirate, inject the medication, and withdraw the needle smoothly. The site is not massaged afterward. Intramuscular injection is a method of delivering medication directly into muscle tissue, which has a richer blood supply than subcutaneous tissue, allowing for faster absorption. It is especially useful for drugs that irritate subcutaneous tissue or require larger volumes. Because absorption depends on drug solubility and local blood flow, effects appear more quickly than with subcutaneous injections. The advantages of intramuscular injection include the ability to administer irritating drugs more safely, the capacity to hold larger amounts of solution, and relatively rapid absorption. The disadvantages include the risk of nerve and blood vessel injury, pain and anxiety, faster onset of side effects compared with oral administration, and the possibility of infection, air embolism, or tissue damage. Several injection sites are used. The dorsogluteal site has a thick muscle layer but the slowest absorption. It is used in adults and children over 3 years old, but care must be taken to avoid the sciatic nerve by identifying the upper outer quadrant between the posterior superior iliac spine and the greater trochanter. The ventrogluteal site is preferred because it has fewer nerves and blood vessels, less fat, and reduced risk of contamination. It is suitable for adults, children over 7 months, incontinent patients, and obese individuals. To locate it, the palm is placed on the greater trochanter, the index finger on the anterior superior iliac spine, and the middle finger along the iliac crest to form a V. The vastus lateralis muscle is thick and well developed, free of major nerves and blood vessels, making it safe for adults and especially for infants and young children under 3. It is found in the middle third of the anterior lateral thigh, between the greater trochanter and lateral femoral condyle. The rectus femoris muscle, also on the anterior thigh, is sometimes used for self-injection or when other sites are not available, especially in long-term immobilization. The deltoid muscle, though small and near the radial nerve and artery, provides the fastest absorption and is chosen for vaccines such as hepatitis B or for medications requiring rapid effect. It is located about 5 centimeters below the acromion. Complications of intramuscular injection include peripheral nerve injury, such as sciatic or radial nerve damage, embolism if oily, or wax-based drugs enter the bloodstream, muscle contracture from repeated injections, tissue necrosis or abscess formation, periostitis if the periosteum is irritated, gas gangrene from contaminated needles, and localized pain or induration. Repeated injections into the same site may create nodules, particularly with drugs like iron preparations or antibiotics such as penicillin, which are poorly absorbed if administered subcutaneously. The standard procedure involves cleaning the skin, inserting the needle at a 90-degree angle, aspirating gently, injecting the medication slowly, and withdrawing the needle quickly. Pain can be reduced by using a fresh needle for injection, injecting into a relaxed muscle, inserting and withdrawing swiftly, injecting the drug slowly, and avoiding excessive volume. Ice packs and reassurance may also help. For irritating drugs, the Z-track technique or airlock method is recommended. The Z-track method is designed to prevent leakage into subcutaneous tissue and reduce staining or irritation. The skin is pulled about 2.5 centimeters to one side, and a needle of at least 1.5 inches is inserted deep into the muscle. After confirming no blood return, the medication is injected. The needle is removed after about 10 seconds, and the skin is released to seal the track. Massage is avoided to prevent leakage. Drugs commonly given by this method include iron dextran, which can cause permanent discoloration if it enters subcutaneous tissue, and penicillin or lincomycin, which are painful and poorly absorbed outside muscle tissue. Intravenous medication. Intravenous, IV administration, delivers medication directly into the bloodstream, allowing for immediate and complete absorption. It is especially important for emergency drugs, which act quickly when given intravenously. Continuous infusion can maintain a constant therapeutic blood level, and IV delivery allows administration of drugs that cannot be absorbed through the gastrointestinal tract or are destroyed before absorption. With one venipuncture, multiple doses can be given easily, and IV therapy also enables the supply of fluids and blood products to maintain hydration, electrolyte balance, and nutritional support. The disadvantages of intravenous administration include the risk of local or systemic infection, the rapid onset of side effects that are difficult to reverse if errors occur, the potential for fluid overload and electrolyte imbalance during continuous infusion, and the risk of vascular, nerve, or tissue damage. It is also costly, cannot be performed outside medical settings, and sometimes it is difficult to secure peripheral venous access. Complications and nursing interventions. Local infection may occur when microorganisms enter through the puncture site, leading to systemic involvement. Symptoms include chills, fever, pain, swelling, or purulent discharge, often within an hour of infusion. Causes include contaminated equipment, poor hand hygiene, or inadequate skin disinfection. Treatment involves removing the IV, changing the site, and applying cold compresses, while prevention requires strict aseptic technique and proper hand washing. Infiltration or extravasation occurs when fluid leaks into surrounding tissue due to vein rupture, dislodgement of the needle, or improper placement. This leads to local swelling, pain, and, if large amounts leak, circulatory compromise or nerve damage. Certain agents, such as hypertonic solutions, calcium preparations, vasoconstrictors, or chemotherapy drugs, cause severe tissue damage if extravasation occurs. Intervention includes stopping the infusion immediately, restarting at another site, elevating the affected limb, and applying cold compresses to reduce swelling and pain. Prevention includes selecting large veins, securing the cannula properly, using splints if needed, inspecting the insertion site frequently, and stopping infusion if resistance is felt. Catheters are preferred over butterfly needles for safety. Phlebitis, or inflammation of the vein, can also occur. The interaction between the IV catheter and the venous wall leads to fibrin deposition and formation of a fibrous sheath, which may progress to thrombotic phlebitis. This condition can cause pain, redness, swelling, and warmth along the vein. Strict aseptic technique, rotation of infusion sites, and careful monitoring reduce risk. Topical medication administration. Topical administration involves applying drugs directly to the skin or mucous membranes for local or systemic effect. Before applying, the skin should be cleaned with soap and water to remove any residue from previous applications, which enhances absorption. Sterile gloves are required if the medication is applied to infected areas. For skin application, different forms of drugs are used. Lotions are shaken before use and gently spread without rubbing to relieve irritation or adjust skin pH. Emollients soothe irritation of skin and mucous membranes and are spread evenly with a spatula. Ointments used for soothing, disinfecting, or antibacterial effects are applied thinly with a finger, using a septic technique for open wounds. Pastes are similar to ointments, but absorb secretions and protect wounds from contamination. Liniments containing analgesics or rubefacents are applied with gloves and rubbed in to stimulate circulation. Powders protect the skin by forming a barrier, applied thinly and covered with gauze. Creams and oils act as lubricants to soften the skin. Astringents and alcohol provide a cooling effect. Transdermal adhesive patches deliver drugs steadily through the skin into the bloodstream. For eye medication, the cornea must not be touched due to high sensitivity. Drops or washes are instilled into the conjunctival sac of the lower eyelid. The inner canthus is pressed for 30 seconds to prevent drainage into the nasolacrimal duct. For ointments, a thin line is applied from the center to the outer edge of the lower lid, after which the patient gently closes the eyes and moves them to spread the medication. Excess is wiped away with sterile gauze. For ear medication, the patient lies with the affected ear upward. In adults, the auricle is pulled up and back. In children, down and back. Solutions are given at room temperature. Ear irrigation is performed with the head tilted toward the affected side. For nasal medication, drugs such as vasoconstrictors, antihistamines, steroids, or local anesthetics are applied to reduce congestion, swelling, and inflammation. Drops should not exceed 3 per nostril, and the patient remains in position for about 5 minutes to allow absorption. Specific head positions, such as the Proetz or Parkinson methods, help target different sinuses. Nasal sprays should be applied gently to avoid forcing organisms into the middle ear. For vaginal administration, suppositories are lubricated and inserted 8 to 10 centimeters into the vaginal canal with a gloved finger after the patient has voided. Creams, gels, or foams are inserted with an applicator. The patient remains supine for 5 to 10 minutes afterward to allow absorption, and a sanitary pad or T-binder is provided. For rectal administration, the patient is placed in the left Sims position. The suppository is lubricated and inserted gently, 10 centimeters for adults, 5 centimeters for children, beyond the internal sphincter, against the rectal wall, not into stool. The buttocks are held together, and the patient is encouraged to retain the medication for 30 to 40 minutes if it is a laxative, or at least 5 minutes for other drugs. Documentation should include the medication given and the patient's response. Blood transfusion. A blood transfusion involves transferring blood or blood components from a donor to a recipient. The recipient is the patient receiving blood, and the donor is the individual providing it. Pre-transfusion testing includes ABO and RH typing, as well as cross-matching, where the donor's red cells are mixed with the recipient's serum and vice versa to ensure compatibility. Transfusion is only possible if no hemolytic reaction occurs. Donor selection requires individuals who are free from infectious or chronic diseases, stable in vital signs, and not involved in high-risk behaviors such as unsafe sexual activity or intravenous drug use. Blood components are used based on clinical need. Whole blood, 320 to 400 milliliters, is used to restore volume and oxygen-carrying capacity in cases of hemorrhage. Packed red blood cells increase oxygen-carrying capacity without significantly increasing volume. Platelet products, such as platelet-rich plasma or concentrates, are indicated for bleeding due to thrombocytopenia. Plasma products, such as fresh frozen plasma and cryoprecipitate, are used to supplement clotting factors in conditions like liver disease, disseminated intravascular coagulation, or hemophilia. Transfusion procedure requires a large vein with a 15 to 19 gauge needle or catheter, often 16G. Normal saline is used as the compatible infusion fluid. Whole blood or packed cells are usually given over 2 to 4 hours at 25 to 50 drops per minute. Before transfusion, the physician's written order, patient consent, and compatibility test results must be confirmed. Blood identity is checked at the bedside, and vital signs are taken. After transfusion begins, the patient must be observed closely for the first 5 to 15 minutes, since most adverse reactions occur during this time. Vital signs are then measured every 15 minutes for half an hour, and then every 30 to 60 minutes as per institutional policy. Documentation must include the time, amount, type of blood product, blood unit number, and the nurse's signature. Precautions include starting with normal saline, ensuring blood is warm to body temperature, avoiding shaking during transport, not adding other drugs into the transfusion line, and preventing rapid infusion that can cause circulatory overload. Adverse reactions and nursing care include circulatory overload, managed by slowing infusion, and transfusion-transmitted diseases, prevented through strict donor screening. Febrile reactions, the most common, result from leukocyte or platelet antigens, causing sudden chills and fever. The transfusion must be stopped, temperature checked, and antipyretics given. Bacterial contamination may cause fever, hypertension, flushing, abdominal pain, and requires immediate cessation of transfusion, cultures, and antibiotics. Allergic reactions result in fever, itching, rash, urticaria, or laryngeal edema, and are treated with antihistamines or steroids. Hemolytic reactions from ABO incompatibility present with chills, fever, flushing, hypotension, headache, chest tightness, back pain, tachycardia, or shock. Management includes immediate cessation of transfusion, changing the IV set, running saline, notifying the physician and blood bank, and monitoring vital signs every 10 to 15 minutes while sending leftover blood and urine samples to the lab. Other complications include hyperkalemia from old stored blood, hypocalcemia after massive transfusions, and air embolism